Today's lecture topic is the enhancing acupuncture with osteopathic diagnosis and treatment. And our honorable lecturer, Tianyi Max Jin, is a registered osteopath and medical acupuncturist. He is specialized in treating musculoskeletal pain and disorders and stress-related illnesses. He graduates from Swansea University with first-class honors in Master of Osteopathy. He also holds a bachelor's degree in biochemical science and medical physics from University College London. And his paper, Osteopathic and Acupuncture Management of Sacroiliac Joint Dysfunction in Low Back Pain, earned him the Outstanding Paper Award organized by the World Federation of the Acupuncture Mox-Bustian Societies. So, in today of the lecture, Max will explore how could the osteopathic diagnosis and treatment enhance acupuncture practice. And the topics include osteopathic principles, assessment, and hands-on techniques. And there is a question and answer session for about 20 minutes at the end of the lecture. And now, please welcome our honorable lecturer, Max Jin. And he will talk about today's topic, enhancing acupuncture with osteopathic diagnosis and treatment. Thank you, Max.
Okay,
Welcome.
Thank you.
Thank you.
Thank you, Dr. Zhang, for your wonderful introductions, and thank you everyone for having me. So I'll just share my screen with you now. Okay, so can everyone see my presentation? Okay, great. So again, my name is Max. So I'm a registered osteopath and medical acupuncturist, and I'm currently practicing here in Leicestershire. So today I'll be talking about how we can use osteopathic principles to help enhance acupuncture. So with this presentation, I want to share with you what osteopathy is, how we look at the human body, and our understanding of disease. I also want to share some of the methodologies we use to determine what to treat and how we treat. And so by the end of this presentation, I hope you're able to relate to the osteopathic principles and maybe find some use for it in your own practice. So what is osteopathy then? So this is a very complex question, and its definition varies depending on who you ask and which part of the world you ask it in. For example, the General Osteopathic Council, the governing body of osteopathy in the UK, defines osteopathy as you can see as such on the slide. So this definition provides a simple illustration of osteopathic philosophies and practices here in the UK, but there's no perfect definition of osteopathy, as it's such a broad subject with so many different facets. But at the core of the answer, we can say that osteopathy is what osteopaths do. And so we'll explore who was the first osteopath. So pictured here, you can see is Andrew Taylor Still. He was born in 1828 in the US state of Virginia. He was born into a medical family, and in his early career, he became a frontier doctor himself. He enlisted with the Union Army during the American Civil War, where he became a major. But also during the war, he also used his skills in medicine as a military surgeon to help the wounded. But as you can imagine, the medicine of the 19th century was quite brutal and very rudimentary. And the surgeries and the interventions caused many more deaths from sickness and infection than from the battlefield injuries themselves. So in October 1864, Still went home after his unit was disbanded, but it wasn't a joyful homecoming. So earlier in the year, in 1864, his 3 children had all died of cerebrospinal meningitis, despite the best efforts of the physicians that were called to help. And so all around him still saw people who had become addicted to alcohol or morphine after their return from the Civil War. And so in light of these experiences with the medicine of his time, Still devoted the next decade of his life in search for a better way. And so in 1874, through the influence of Indian herbal medicine, homeopathy, magnetic healing, and bone setting, which is a form of manipulation, a traditional form of manipulation, still proposed a different model for treatment and diagnosis that mediated principally by the musculoskeletal system, but also recognized that the great importance of the blood supply, as well as the body's inherent capacity to self-regulate and cure itself. So he coined the term osteopathy in 1885, but only in 1889 did he start calling himself an osteopath. Still founded the American School of Osteopathy in 1892, and it quickly caught on, growing both within the US and then globally. So, through Still's writings and teachings, osteopathy developed its core tenets, which is stated as follows. So the body is a unit, structure governs function, the rule of the artery is supreme, the body possesses self-regulation and self-healing mechanisms, and that rational treatment is based on these principles. So while simple, we need to do some explaining to appreciate the depth behind these words. Still was a devout Christian. He viewed the body as divinely designed by God, who was the architect, and he has perfectly integrated each part of the body into the whole. He compared the human body to an organized city, with every organ acting as a skilled worker united by the fascial system, a connective tissue that links all systems anatomically and functionally. So the nervous system coordinates these interconnected elements. Changes within one area prompts adaptive responses across others, and that preserves harmony. So Still recognized that changes in anatomical structure directly influences bodily function, and he extends this concept beyond pathology into normal physiology. He emphasized circulation, at the rule of the artery, and noted structural disturbances cause local and global functional consequences. And so as osteopaths, we palpate and correct these structural issues to enhance overall health, understanding that structure and function are inseparably linked at all levels. The fascia illustrates this interconnection, and it forms a continuous network from macroscopic organs down to individual cells, where alterations create cascading and functional impacts. So Still believe the body possesses self-healing mechanisms, and that's now understood as the homeostatic functions. So these regulatory processes constantly maintain internal balance via hormonal and neural pathways. So Still's holistic approach considers body, mind, and spirit as inseparable, emphasizing that any alteration in one domain influences the entire unified system. And so osteopathic practice integrates anatomy and physiology, emphasizing holistic treatment by addressing structural disruptions to restore bodily harmony. And so as practitioners of osteopathy, we remove dysfunction, allowing the body's inherent self-stabilizing and self-healing mechanisms to restore health naturally. So to further expand on the philosophies that's been built on top of Still's founding principles, we'll have a look at a selection of concepts that osteopaths have developed to aid their understanding of the human body and how it functions. So these include structural concepts and the spine, the paradigm of tensegrity, the importance of respiration and circulation, the nervous system, and the psychological considerations. These come together in the concept known as the total osteopathic lesion. But I have to say that these models are not prescriptive, but they only serve as a guide for ease of understanding, as no model is able to fully describe the rich variety and complexity of our body. So to start from the spine then, so from the moment we are born, we start a lifelong battle against gravity. Our spine begins in a natural kyphotic state that's shaped like a C, and so there is only one curve that we call the primary spinal curve. By week 8 of development, we can start to lift our head against gravity, and so our cervical muscles have developed, and this forms the first secondary spinal curve in our cervical spine. Crawling and then standing further strengthen the spine and the erector spine muscles. which combined with the strengthening of the hip flexors and extensors creates the secondary spinal curve in our lumbar spine. So what we're left with then is a spine that everyone should be familiar with. So we've got the lordosis of the 7 cervical vertebrae, kyphosis of the 12 thoracic, lordosis again of the 5 lumbar vertebrae, and then another kyphosis in the fused 5 sacral and 4 coccygeal vertebrae. So as you can see, our primary curve still persists partially in the thoracic spine, the sacrum, and also the cranium, whereas the secondary lordotic curves are in the cervical and lumbar regions, and they evolved for our upright posture. So these secondary curves are more mobile, enabling movement between the stable and protective regions that house our vital organs. So structurally, the spine balances stability and mobility through 3 pillars. A large anterior pillar with the vertebral bodies and discs for weight bearing, and then 2 posterior articular pillars for the facet joints that permit movement. And all this enclosed by protective arches that safeguard the spinal cord. And so the spinal structure reflects a functional compromise between protection, adaptation, and mobility. So the soft tissues of our muscles and connective tissue play a vital role in balancing the curvature of the spine. So the body's upright posture relies on the balanced interactions between strong posterior extensor muscles and the weaker anterior flexors. When looking at postural imbalances, we often emphasize hypertonic extensors, but we often overlook the weaker flexors, although their hypotonia significantly impacts the posture. So for example, the weak abdominal muscles here can reduce trunk support, causing the viscera to move forward, and that increases the leverage on the spine, which increases our lumbar lordosis. So in these cases, treating the site of the spine in the back provides temporary relief, but lasting improvement, it requires addressing the primary muscular weakness that's in the front. Ultimately, posture depends on a complex synergy among bones, fascia, muscles, and the internal structures. Dysfunction in one area will affect the entire region and the entire system. And that's a principle that's best understood through the concept of tensegrity, which we'll have a look at next, rather than the traditional Newtonian mechanics. So tensegrity is an architectural term with historical roots dating back to the 1920s. The term tensegrity combines tension and integrity, and it describes structures whose stability relies on an intricate balance between tension cables and isolated compressive struts. Tensegrity structures distribute forces evenly throughout the entire system. So consider this simple stick and string model. So we have the separate rods, the compression elements, that's pushing against the continuous elastic cable, which is the tension element. If we tighten one part, all components respond simultaneously and uniformly, maintaining equilibrium. So this internal balance of tension makes the entire structure dynamically stable. So tensegrity emphasizes synergy, the idea that the structure's overall balance emerges uniquely from the interaction of all its components. So ultimately, tensegrity provides a powerful tool for understanding the human body and its skeletal system, which is the compression element, and the soft tissue, which are the tension elements. So we can imagine how imbalances in tissue tension can impact the position of a vertebrae, and the changes this can cause further down the chain. So tensegrity highlights how local change impacts the whole, and then we can see how that affects a patient. So like in the case with the weaker abdominal flexors affecting the spinal curvature that I discussed before, patients may present with complex biomechanical and soft tissue restrictions throughout their body, which can cause postural strains and a range of diverse symptoms. For example, head torsion can lead to TMJ pain, headaches, or chronic ear congestion. Thoracic restrictions can manifest as respiratory issues or indigestion, and then pelvic torsions might affect the lower limbs, but also the bladder or the prostate. while coccygeal tension can influence uterine function. So identifying the primary dysfunction is challenging, but effective management depends on accurately interpreting these patterns and then applying targeted therapeutic interventions that align with the patient's symptoms and overall physiological needs. So we must therefore maintain an open-minded and integrative approach when assessing our patients. Rather than treating mere symptoms, it's essential to explore deeper structural and functional relationships, considering both local and distal influences. So the meridian system of TCM is excellent in this regard. It provides a framework for thinking distally and prompts examinations of limbs or areas you wouldn't normally associate with the pain. But ultimately, understanding that each patient embodies a unique interplay of structural compensations and functional adaptations guides us towards precise and therapeutic strategies. Next, we'll talk about the nervous system, which is central to both acupuncture and osteopathic practice. So it orchestrates the balance within the body and collaborates with the endocrine and immune systems to maintain health. Structurally, it's divided into the central nervous system, the peripheral nervous system, which includes the autonomic nervous system, and that's further divided into the sympathetic and parasympathetic branches. So mastery of these divisions and their functions is crucial to understanding osteopathic interventions, but also acupuncture. So reflexes, as you can see here, exemplify the nervous system's integrative capacity. So in this monosynaptic stretch reflex, the muscle spindles detect stretching and instantly send signals to the spinal cord. And that prompts the motor neurons to contract the muscle and preserve stability. So the concept of reciprocal innervation refines this idea by showing that one muscle group contracts, the opposing group automatically relaxes, supporting fluid, efficient movement. In somatic dysfunction, this balance is disrupted. So excessive side bending or other stresses can overstretch a muscle, activating this protective contraction via the spinal reflexes. If these reflexes fail to resolve the original issue, the muscle remains engaged and creating what we call a facilitated segment. So this segment reflects chronic neural hyperactivity at this specific spinal level. This hyperactivity leads to sensitization, pain, and then we'll see on our next slide how it can disrupt the visceral systems as well. So the facilitated segments could influence both the local tissue and distant visceral structures. So this connection occurs because the sympathetic nerves supplying the internal organs share the spinal segments with sensory nerves from specific skin areas, forming a reflexive link. This reflex connection operates in two directions: viscerosomatic reflexes, where organ dysfunction affects the skin or muscle, and somatovisceral reflexes, where musculoskeletal dysfunction impacts internal organs. So this is the concept of referred pain, where visceral disorders manifested pain or sensitivity in specific regions far away from the affected organ. So understanding this relationship allows us to treat somatic structures and alleviate visceral pain or dysfunction indirectly, especially when direct visceral treatment isn't feasible. We also need to familiarize ourselves with the autonomic nervous system, so the ANS encompassing the sympathetic, which are the thoracolumbar nerves, and the parasympathetic, the cranial and sacral divisions. So these govern essential functions like heart rate, digestion, and respiration through the spinal and cranial nerve pathways. So because these pathways run alongside the spine and directly into target organs, osteopathic techniques and also acupuncture that addresses the spinal segments can have wide-ranging effects, from alleviating headaches via improved cranial blood flow to enhancing pelvic organ function through the sacral parasympathetic stimulation. So next, we want to talk about the importance of fluids and circulation. So as still taught that the rule of the artery is supreme, so this idea has evolved into a broader understanding that the movement of body fluids is essential to health. While we often think of blood when we mention fluids, it is important to realize that blood only accounts for about 5 liters, or just 8% of our total body fluid count. The human body is made up of around 42 liters of fluid, or around 60% of our body weight, and that includes both intracellular and extracellular fluid. Fluids serve many essential roles, from delivering oxygen and nutrients, removing waste, enabling hormonal and immune communication, and supporting tissue structure. So, for example, the lymphatic system is part of this fluid network, and it not only returns escaped fluids to the bloodstream, but also plays a critical role in immune defense. Fluids also help support structure. For example, the cerebrospinal fluid cushions and protects our central nervous system. Also, fluids fill fascial cavities, which supports the structure of our body through tensegrity. Importantly, fluid movement doesn't rely solely on the heart. It's also driven by respiration, muscle contraction, peristalsis, and the natural mobility of the tissues and the organs. So somatic dysfunction or postural imbalance can interfere with these pressure gradients, leading to fluid stasis, hypoxia, or impaired tissue function. Fluid movement in the body is never passive. It's always intimately linked with tissue mobility, diaphragmatic motion, and pressure changes within the body's cavities. So the thoracic diaphragm plays a central role. With every breath, it creates a rhythmic pressure shift, drawing fluid into the tissues during inhalation and then encouraging drainage during exhalation. So this respiratory pump is one of the most important mechanisms that supports venous return and lymphatic flow. In addition to the thoracic diaphragm, we have other diaphragms, such as the pelvic floor, the thoracic inlet, or other known as the Simpson's fascia, and the tentorium cerebelli in the cranium. These all act as regulators of regional pressure and fluid exchange. Dysfunction in any of these areas can lead to local stagnation and a systemic ripple effects. So furthermore, the fascial compartments throughout the body form a web of small and large chambers through which the fluids must travel. If these tissues become restricted through trauma, postural strain, or inflammation, fluid flow becomes obstructed, and that affects not only the circulation, but also cellular communication, the detoxification, and our immune function. So our treatment should then seek to restore the fluid tide, this rhythmic and subtle, but essential motion that supports life at every level. So next, we want to look at the psychological considerations when it comes to patients. So the mind-body connection is one that is focused on in osteopathy, and then stress is the main source of dysfunction in this system. So the physiologist Hans Selye popularized the term stress in 1936 and introduced the concept of the general adaptation syndrome to describe how our body responds to stress. So according to Selye, when we encounter stress, whether that's physical, chemical, or psychological, the body reacts through 3 distinct stages. So the alarm, resistance, and exhaustion phase. Initially, in the alarm phase, the body mobilizes resources rapidly, leading to increased heart rate, increased respiratory rate, reduced digestive activity, and a heightened alertness to confront the immediate threat. So this is our normal physiological response. But if the stress persists, the body enters the resistance phase. And that's adapted by activating hormonal pathways, especially the hypothalamic pituitary-adrenal axes. So while this helps manage stress in the short term, prolonged resistance might lead to adaptation-related illnesses, such as hypertension, ulcers, and reduced immune function. Eventually, if stress continues without relief, the body enters the exhaustion phase. And that's characterized by depleted resources, compromised immunity, impaired healing, and potential organ damage. Without intervention, this phase can lead to serious health consequences or even death. So understanding these stages helps us to identify and manage stress more effectively, intervening before we reach the harmful exhaustion phase. So building on the general adaptation syndrome, we have the concept of allostasis, which means maintaining stability through change. So unlike the older idea of homeostasis, which implies a fixed internal balance, allostasis recognizes that the body is constantly adjusting to meet demands. It's a dynamic and flexible process that's driven by the brain's perception of stress and regulated through the nervous, endocrine, and immune systems. However, repeated or prolonged activation of these systems comes at a cost, and that's called allostatic load. So this is the wear and tear on the body that accumulates when stress responses are triggered too often, fail to shut down properly, or when the body cannot mount an adequate response. So these maladaptive patterns can lead to chronic conditions like cardiovascular disease, metabolic dysfunction, and persistent inflammation. Importantly, not everyone reacts to stress the same way. Genetics, personality, coping mechanisms, and perception can all influence how much allostatic load a person carries. So in clinical practice, this explains why some patients with seemingly similar lifestyles or diagnoses present very differently, yet all may stem from the same core problem, and that's chronic stress overloading our adaptive systems. Apart from stress, then, we must take into account a patient's beliefs about their health. Ultimately, the patient has the primary responsibility for their health, and our patient-physician relationship is a partnership. We have to guide the patient to health, emphasizing health restoration and disease prevention, rather than curing disease itself. So the term yellow flags is used to identify risk factors that's based on the patient's beliefs, behaviors, emotions, and social environment, and how these might interfere with the recovery. So patients who believe that they must be completely pain-free before resuming activity, or those who fear movement, often develop a passive approach that impedes recovery. Catastrophizing can similarly lead to chronic symptoms, and excessive rest, erratic exercise, poor sleep, self-medication, or social withdrawal can also add further risk. Broader influences include compensation disputes, distressing diagnoses, emotional issues, and unhelpful family or workplace situations. So consequently, chronic pain is shaped by more than just physical factors. The mindset, coping strategies, social support, and employment conditions of the patient will all impact the outcome. So by recognizing these psychosocial elements, we can encourage active rehabilitation, reduce fear avoidance behaviors, and collaborate with other professionals for holistic care. So to put everything together, in osteopathy, we don't just treat the symptoms, we have to look at the whole person. So this approach is embodied by the concept of the total osteopathic lesion. So rather than focusing solely on structure or a single diagnosis, the TOL encourages practitioners to explore the full spectrum of influences on a patient's health. So historically, AT still emphasized that health involved mind, body, and spirit in harmony. Later, this is refined into the term we now use, the total osteopathic lesion, or other known as the biopsychosocial model. So the TOL is often illustrated using this Venn diagram, and it shows the overlapping spheres. We have mechanical here, which include the musculoskeletal system, the physiological, which include the endocrine, immune, or viscera, and the psychological, so the emotional and spiritual aspects of the patient. And this is all influenced by the patient's external environment. So each factor interacts with the others. For example, chronic stress, a psychological factor, can affect posture, a mechanical, and that can influence immune function, a physiological. So trauma, poor diet, grief, repetitive strain, or bad relationships all contribute to the individual's total load. So to apply this model, we have to consider the cumulative stresses across the patient's lifespan, and we have to create a clinical temporal profile. So that's a timeline of physical and emotional challenges that may have contributed to their current condition. So the TOL teaches us to ask not just what hurts, but why now and why this patient. So we can imagine every stressor, whether that's physical injury, illness, worry, poor sleep, as costing units of energy or resilience. So we all have a threshold, a point where the system can no longer compensate. If someone accumulates too many of these stresses, even a minor trigger, like a cold or an argument, can push them over the edge. So their system decompensates, and then disease or crises emerges. So in this view, the final straw is rarely the sole cause, but it's the sum of all the burdens. So our job is not always to find and fix a single lesion. Instead, it might just be to help lighten the overall load, whether that's restoring mobility, improving fluid flow, calming the nervous system, or just help support self-regulation. And so by removing just enough burden, we allow the body's self-healing capacity to re-engage. So whether we use touch, lifestyle guidance, or just simply listening and understanding the patient's lived experience. So now that I've introduced our concepts, so let's put it all into practice. So I have mentioned the term somatic dysfunction or the osteopathic lesion previously. So I'll now explain what it is and why it's so important to the osteopaths. So the osteopathic lesion is a concept that's at the heart of osteopathy, and yet it's famously challenging to define. In many ways, it's as elusive as osteopathy itself, but historically, osteopaths have used the term osteopathic lesion, but modern practitioners often prefer somatic dysfunction to clarify that we're dealing with a functional issue rather than a pathological one in the allopathic sense. So somatic dysfunction is defined as the impaired or altered function in part of the somatic framework, which include the bones, muscles, fascia, nerves, and blood vessels. So to keep it simple, if osteopathy is what osteopaths do, somatic dysfunction is what osteopaths find. So we'll discuss now what we're looking for. So when assessing dysfunction, we have to consider two perspectives: quantitative and qualitative. So quantitative measures how far something moves, and qualitative assessment explores how it moves. So we'll start with the quantitative assessment. So this deals with the measurable ranges of motion. So every joint or structure has both an active range, the movement that the patient performs voluntarily, and a passive range, movement that is introduced by an external force, such as the practitioner's guidance. So the concept of barriers is very important, as is knowing the expected range of motion of the structure you're assessing. So when it comes to barriers, we have three. So first, we have the physiological barrier. So this is the endpoint of active movement, and it's limited by the normal muscle and fascial tension. Next, we have the anatomical barrier, and this is the endpoint of passive movement, where the joint or tissue physically cannot move further without causing structural damage. So if a practitioner carefully applies gentle pressure beyond the patient's active range, they may approach this anatomical barrier. Next, we have the restriction barrier. So in cases of somatic dysfunction, movement is often curtailed before reaching the physiological barrier. So for example, in this case, the vertebrae may freely rotate to the right, but stop early when rotating to the left. So we call this a right rotator lesion, named after its direction of ease, not restriction. So examination this way helps distinguish a purely structural or pathological limitation so such as arthritic changes, restricting movements in all directions, or a functional barrier, such as a muscle or fascial tightness, restricting movement in one main direction. So for further insight into the limitation and what's causing it, we have to assess the quality of the movement, which brings us on to the qualitative assessment. So here we rely on palpation, observation, and patient feedback to gauge the tissue integrity. First, we assess the end feel of movement. So as we approach the barrier, we ask ourselves, does the movement stop with a soft elastic quality, which is often explained by muscular blockages, a firm rubbery quality, which is often ligamentous, or a hard abrupt block, which is usually bony? So this helps differentiate, for example, acute muscle spasm from a chronic capsular restriction. We also have to note any tissue texture changes. So in acute dysfunction, tissues may feel boggy or swollen, and that reflects the inflammation and local vasodilation. Over time, chronic changes lead to the tissue feeling cooler and drier and possibly fibrotic. So palpation will offer clues about the lesion's age and severity. Next, we want to assess the movement fluency. So is the joint or tissue movement smooth and rhythmic, or does it catch, click, or exhibit crepitus? So a simple ratchet feeling could indicate muscle guarding, while a springy block might suggest a meniscal issue or other internal derangement. Finally, we want to note the temperature and tenderness of the tissue. So an inflamed region is often warm and tender initially, but chronic dysfunction reduces local perfusion, sometimes making tissue cooler or even numb. Tenderness alone doesn't always reveal the lesion's importance, but some chronic dysfunctions show minimal pain, but remain quite limiting. So we can use mnemonics to summarize these clinical findings. So START is a classic, and that's so S standing for symptom reproduction, and then T for tissue texture abnormalities, A for asymmetry, R for range of motion abnormalities, and T again for tenderness. So by combining these clues, we can pinpoint the nature and chronicity of a dysfunction, and then distinguishing, for example, an acute inflammatory presentation from a chronic fibrotic state. As Still and others emphasize, the osteopathic lesion is not merely a single point of pain, but it's a dynamic web of changes in tissues, alignment, and physiology. So understanding these subtle but crucial findings helps us tailor an intervention that restores function and facilitate the body's self-healing potential. So when we found what we want to treat, we'll have to choose an appropriate approach to treatment that matches the patient's individual needs, and then we need to apply it in a way that achieves the best possible outcome, whether that's resolution of the issue itself or just relief of symptoms. First, we have to think of treatment as a continuum, as shown in this diagram. So here on this side, we have structural techniques, and these are characterized by more direct interventions where we take the dysfunctional unit towards its restrictive barrier. Techniques like the HVT or the high velocity thrust articulations or muscle force, muscle energy techniques will all fall here. On the opposite end, we find functional techniques, and these use indirect methods by moving the dysfunctional unit away from the restrictive barrier, finding a new balance which eases tension and provides relief. Beyond function, we have energy approaches, which requires a bit of a higher level of manual subtlety and understanding. So these can then be applied through minimal or maximal interventions. So minimalist approach focuses on locating the primary lesion and correcting it with as little input as possible, treating a very specific area. In contrast, the maximalist approach addresses numerous areas and often the whole body. to bring about an integrated global change. So I'm sure you can appreciate that acupuncture also can fit itself onto this model. But where does it fit? Well, that depends on how you needle and what approach you take. So you can take a minimalist structural approach with techniques such as dry needling or an functional or maximalist approach through the traditional meridian acupuncture. But again, we must assess the patient and then apply the best approach that fits their needs. So now we'll have a look at a few manual techniques that we use in our treatments. So these techniques will often have indications such as muscle spasms, localized pain, reduced range of motion, or just general stiffness. But then contraindications to these manual treatments include open wounds, acute inflammation, severe osteoporosis, or with areas of suspected fracture. So first up, we have soft tissue techniques. So these are your typical massage-like approaches that's aimed at relaxing muscles and improving circulation. They can act as an introductory technique to help the patient to relax and settle into the treatment. But I like to sometimes substitute this with acupuncture, as I find that acupuncture allows the patient to enter a deeper relaxation that prepares the body for some of the techniques we'll cover next. So we have the muscle energy techniques. And here we use the patient's own muscle contractions to improve joint mobility. This technique uses the body's reflexive relaxation to help lengthen tight muscles and re-educate neuromuscular control. Joint mobilizations then use passive movement to help restore proper joint motion. And this helps reduce pain, stretch joint capsules, and just improve the overall joint function. So manipulations, other known as the high velocity, low amplitude thrust, are quick, precise thrusts that's aimed at freeing up joint restrictions. So with this technique, we take the joint to its restricted barrier, and then we apply a short but rapid thrust without exceeding the physiological range. So this can help overcome any adhesions, stimulate mechanoreceptors, and reset the neuromuscular reflexes. And all this helps restore normal joint motion, alleviate pain, and reduce muscle guarding. Next, we have strain counter-strain, which is an indirect technique which provides pain relief by gently positioning muscles into their position of comfort or ease. So this technique resets the muscle spindle reflex and helps calm hyperactive reflexes in the muscle, which reduces spasm and alleviates pain. Next, we have visceral manipulation, which focuses on improving organ mobility and function by working with the fascia and ligaments around the internal organs. So we can use gentle, specific palpations to help find restrictions in the organ motion, and then we apply subtle pressure to mobilize the tissue. By releasing the fascial restrictions and tension, we can promote better fluid circulation and neural communication, aiding with organ function. And finally, we have cranial techniques, which involve subtle manipulations of the skull to help influence the cerebrospinal fluid flow and help nourish the central nervous system. So this can also help normalize the rhythmic fluid motion around the brain and the spinal cord, reducing stress and just enhancing overall well-being. So acupuncture then is a great tool that we also use. So it helps support and enhance osteopathic practice. We recognize that acupuncture resonates with our holistic and patient-centered philosophy, and that acupuncture needles produce a wide range of systemic effects that's consistent with the osteopathic principles of self-regulation and interconnectedness. We needle because acupuncture has many beneficial effects, which I'm sure you all know. But first of all is its pain relieving effects. So acupuncture relieves pain extremely effectively, which allows us to address the other components of their condition. Mechanically, acupuncture is a very effective tool at relaxing muscular trigger points, and a needle can be manipulated to pick up and stretch fascia, which helps relieve tension, adhesions, and also increase range of motion and reduce pain. So when combined with manual techniques and exercise, this helps accelerate functional recovery. Acupuncture also taps into the spinal reflexes, and that activates descending pain inhibitory pathways in our central nervous system, and which further dampens the pain perception and can complement our efforts to reset dysfunctional neuromuscular patterns. So because acupuncture can modulate sympathetic and parasympathetic outflow, it supports the body's return to a balanced autonomic state. And that's what we want to achieve. Finally, improved blood flow is a hallmark outcome of acupuncture. So heightened circulation brings nutrients to the muscles and joints while assisting in the removal of metabolic waste. And this is vital for tissue repair and healing and complementing the fluid models of osteopathy. On the other hand, I think that osteopathic principles can help support and enhance acupuncture. Osteopathy emphasizes the importance of anatomy and provides a framework that helps us understand precisely how structural imbalances affect the body. So this can help guide point selection, ensuring we're targeting the most relevant meridians and tissues. And so by examining joints, muscles, and fascia for somatic dysfunction, we can identify the issues that could be underlying a patient's pain or dysfunction. So when choosing acupuncture points, we're doing it with a clear anatomical rationale, which both increases the efficacy of the treatment, but also the safety. So let's now have a look at a few common conditions that we can see in clinical practice, and we'll discuss how we approach them. So first we have irritable bowel syndrome, or IBS. So this is a functional gastrointestinal disorder. The most common one we'll probably encounter in clinical practice. So patients often present with intermittent bouts of constipation, diarrhea, or both, along with abdominal discomfort and bloating. Despite its prevalence, that affects up to 22% of adults, there's no clear structural, biochemical, or infectious causes. But from an osteopathic standpoint, the culprit seems to be a disruption of normal gastrointestinal motility and autonomic imbalance. So, excess sympathetic tone can inhibit the normal peristalsis, which leads to indigestion and constipation, while excess parasympathetic activation, while promoting digestion, also promotes elimination, which could lead to diarrhea. So prolonged stress cycles disrupts this fragile balance and exacerbates symptoms. So our approach aims to restore homeostatic function. So we can look at specific spinal levels, for example, T7 through to L2 for the sympathetic outflow, as well as the suboccipital and sacral regions for the parasympathetic innervations. By using articulation of the spine and gentle visceral techniques, we can reduce restrictions impairing the normal bowel function. And then we can also work on the diaphragm and its attachments, which can enhance lymphatic and venous return, alleviating congestion in the gut, but also promoting relaxation. So we can replace the manual techniques with acupuncture, so paraspinal needling from T7 to L2. Also, the sacral paraspinals are very effective. And also abdominal acupuncture can help stimulate the sympathetic plexuses that's in our guts and help normalize our gut functions. So asthma, again, is a very common respiratory condition. It's an inflammatory but often relapsing condition that narrows the airways and causes episodes of wheezing, chest tightness, and difficulty breathing. There's two main types, extrinsic and intrinsic, or allergic and non-allergic. So despite their differences in triggers, both types involve inflammation that leads to heightened airway reactivity, bronchial spasm, and mucus production. So normally asthmatic patients will be using inhalers, which are normally bronchodilators or inhaled anti-inflammatory drugs, but in more severe cases, these could be oral steroids. So the key consideration for asthma is that it involves more than just the lungs. It's a whole body issue that involves the musculoskeletal system, autonomic balance, and even the emotional factors. So sympathetic innervation comes from T1 to 6, and the parasympathetic innervation comes from the vagus nerve, which exits the skull from the jugular foramen. So we want to assess both the thoracic and upper cervical spine for any restrictions that might be impairing normal autonomic nerve function. And next, we can assess the ribs and the muscles of inspiration for any restriction or strain that might impact breathing capacity. So the diaphragm again comes into play, so as it's the main muscle for respiration. We can check its sternal, costal, and vertebral attachments for tension or asymmetry, but also we have to check C3 to C5 to ensure that the phrenic nerve is functioning optimally. Restrictions here can again reduce lung capacity, which overall increases the work of breathing. Finally, we can examine the mediastinum, where the trachea, bronchi, and major blood vessels reside. Gentle release techniques here can help reduce tension that might contribute to vascular congestion and inflamed airway tissues. Finally, let's have a talk about low back pain. So low back pain is one of the most common reasons people seek healthcare. We have to understand that the spine functions as a unit. So intervertebral discs, ligaments, muscles, and fascia all must coordinate effectively. If one part of the system becomes strained, others compensate, which can eventually lead to pain. So structurally, we can characterize low back pain as pain stemming from the lumbar region, sacroiliac region, or the pelvic region. So lumbar vertebrae dysfunction often presents with localized lower back pain, along with radiations along nerve pathways. And this is typically exacerbated by bending or extension movements. Sacroiliac joint dysfunctions, on the other hand, manifest with pain around the buttocks or the posterior hip, and also across the lower back in a band. So this is frequently worsened by weight-bearing activities like standing on one leg or sitting. And lastly, pelvic origin pain can be a broader, affecting from the groin to the lower abdomen, but sometimes accompanied by postural misalignments or pelvic floor symptoms, indicating a more generalized pelvic girdle dysfunction. This table condenses the main soft tissues that will be affected in low back pain. However, low back pain often arises from multiple interconnected factors, and so we must have a look past the individual tissues and consider chains as a whole. So this diagram shows the X-shaped pattern that's influenced through the thoracolumbar fascia. And so you can see how this highlights the relationship between the latissimus dorsi and the gluteal muscles. So it's worth examining contralateral structures for this function then. Other considerations include the superficial backline, which runs from the plantar fascia all the way up to the frontal bone. And so by considering this, we can often treat low back pain through the neck or even through the legs. So thinking back to tensegrity then, we have to look at the whole system to appreciate what the optimal treatment strategy is. Often what may appear to be an isolated back issue is often influenced by distant regions to the body, and also factors such as post-surgical adhesions, abdominal hypotonia, or even the psychosocial stresses. And so the strength of osteopathy lies in looking beyond the site of pain. And so now we're approaching the end of this presentation, but I want to re-emphasize that the overall treatment is more important than what technique we use. Acupuncture or manual therapy are just all tools in our toolbox, and it's up to us to use as we see fit for the best of the patient. And so for a successful treatment, we need to have a proper understanding of what we are trying to treat. And so I hope that today's presentation helped make that a bit clearer. So thank you everyone for listening, and if we have any questions, I'll answer them now. And this is a list of references that you can have a read.